Assalamu alaikum. This is a presentation for medical students by Dr. Mumtaz Ahmadover, and today's topic is nasal septum and its diseases part 2. We have already discussed DNS, so the other diseases we will discuss in this presentation. So, fractures of nasal septum. Etiopathogenesis. Trauma is the most common cause for fracture of the septum, either in road traffic accident, in sports injuries or fight. So, any blow from front, side or below can result in injuries to the nasal septum. The septum may buckle on itself. The fracture may occur vertically, horizontally or crushed into pieces as in smashed nose. Usually it is associated with fracture of the nasal bone. However, in case of lower nose trauma, fracture or dislocation of the septal cartilage is observed without the nasal bone fracture. Septal injury with mucosal tears can cause profuse epistaxis. The fractured pieces of the septum, they may overlap each other as mentioned in the buckling, or they may cause mucosal tear and come into one of the nasal cavity. Types of septal fractures. So, they are basically two types, the gingival fracture and the chevalet fracture. So, gingival fractures, this type of fracture occurs when the blow is from the front. The fracture line, it starts just above the anterior nasal spine, runs horizontally backwards just above the junction of the cartilage, septal cartilage with vomer. The chevalet fracture, it results from blow from below. Due to the blow from below, the fracture line, it runs vertically from the anterior nasal spine upwards to the junction of the bony and the cartilaginous dorsum of the nose. So, when the trauma occur to the nose, this is the septum, this is the mucoperichondrial covering. So, fracture can result, and there may also accumulation of blood known as septal hematoma between the cartilage and the mucoperichondrium. To diagnose the septal fractures, it is important to thoroughly examine the patient. First, examination will show if there is any mucosal tears or any pieces of cartilage or dislocation of the septum in one of the nasal cavity, one thing. Secondly, usually to investigations, X-rays have limited role for the septal injuries. Secondly, CT scan can be done, but simple septal injury, the CT scan is not indicated unless there is a smashed nose or associated facial injuries. Treatment, early recognition and treatment of septal injuries is essential. Hematomas, as just shown in the picture, if it is present, then it should be drained immediately. Dislocated or fractured fragments, they should be repositioned and supported between the mucoperichondrial flaps with mattress sutures and nasal packing. But these procedures, they are hardly required, not in every patient. Few patients you need to perform such procedures. Complications, as already shown in the previous picture, it can give rise to septal hematoma. We will discuss this in the next topic. As septum is a very important structure in supporting the lower part of external nose, so if its injuries are ignored, it can lead to deviation of the cartilaginous part of the nose, giving rise to DNS, or further leading to asymmetry of the nasal tip, columella or the nostrils. Now, septal hematoma. Definition: septal hematoma is basically the collection of blood between the mucoperichondrium of the nasal septum and the septal cartilage. So, this is the septal cartilage covered by the mucoperichondrium. So the blood, it collects between the cartilage and the mucoperichondrium. As all of you should know that the cartilage is an avascular structure and it receives its blood supply from the mucoperichondrium. So once the blood starts collected between the mucoperichondrium and the cartilage will be devoid of its blood supply. So if it should not be treated immediately, it can lead to avascular necrosis of the cartilage. Etiology. The most common etiological factor is the nasal trauma. Then it can occur after septal surgeries, or spontaneously it can occur if the patient has bleeding disorders. Symptoms. The patient may present with blocked nose, pain in the nose, may have headache, frontal headache especially, and pressure over the nasal bridge. Depending upon whether it's a unilateral hematoma or most commonly bilateral, the obstruction can be unilateral in cases of unilateral hematoma, which is little less common as compared to the bilateral hematomas. So in bilateral hematomas, there will be bilateral nasal blockage. Signs. Again, just raising the tip, one can identify the smooth swellings in both sides of the nostrils. But before going towards that, because of the trauma, the nose will be swollen, the tip especially, it will be swollen. Then on vestibular examination, smooth round swellings may be visible in both nasal fossa or in one nasal fossa. You can palpate it with any instrument and it will be fluctuant to see whether, if you just look at it, it may looks like a C-shaped DNS. So you have to take a Jobson horn probe and just press it little, so it may show the mass will be soft and fluctuant. Again, you see, this is the picture. Treatment. Small hematomas, they can be aspirated with wide bore sterile needle and then nose will be packed. However, if the hematomas are large, then they should be incised. Incision and drainage should be carried out, and sometimes you may need to remove a small piece of mucosa from the edge of the incision for better drainage. So after the incising, a suction tip is passed inside to suck out all the blood and to remove any pieces, small floating pieces of the cartilage or anything. So all of it should be drained out, and then anterior nasal packing, and then nose should be packed on both sides to prevent the reaccumulation. So after the anterior nasal packing, we have to prescribe the antibiotics, and also because there is chances that it can lead to infection, the hematoma, so we have to start antibiotics. So systemic antibiotics, most commonly given antibiotic, prescribed antibiotic is co-amoxiclav, which is augmentin. If adult, then tablet in tableted form, and in children you can give the syrup form. Then you have to give syrup brufen or anti-inflammatory and pain medicine along with it. Complications. So it can lead to septal ischemic necrosis, as I already mentioned. If it is not drained immediately and it allowed to stay there, then it will disrupt the blood supply of the septum and lead to ischemic necrosis. Again, if hematoma is not drained, it may organize into fibrous tissue, leading to permanent thickening of septum, as we have seen in the DNS type thickened septum. But the most important is again the secondary infection. If it is not drained in one day or two, it will lead to septal abscess, and once the septal abscess will develop, it will lead to necrosis of the cartilage. All of the cartilage will be necrosed, and there will be depression of the nasal dorsum, which is a saddle nose deformity. So this is the saddle nose deformity. because there is no support underneath this part. The cartilage is necrosed. So this is the summary of what I have told you. After the blood accumulate between the septal cartilage and the mucoperichondrium, the supplies to the cartilage will be devoid, and it will lead to infection, it will lead to necrosis. So these are the ways. All the things I have explained is just the summary of what I have told you. So this is the patient, actual patient with the saddle nose deformity. Now septal abscess. It mostly results from the secondary infection of the septal hematoma. If septal hematoma is not drained, then it will surely give rise to septal abscess. And in some cases also fruncle of the nose or upper lip, if not treated promptly, again will give rise to septal hematoma, septal abscess. Symptoms. So the symptoms will be worsening of the symptoms present for the septal hematoma. There will be severe bilateral nasal obstruction. Patient's pain will be more, he will be feeling more pain. The swelling will be increased in the nose or the face, so the nasopharyngeal swelling will be more. Now the more differentiating point between a hematoma and abscess is fever. Any scenario given in which the patient after trauma has bilateral nasal swelling, but he has fever. When there is fever, it means the infection is there, so it will be septal abscess, and if it is not fever, then it will be septal hematoma. One point. Second point, if the trauma occurs 2-3 days back and the patient present after 2-3 days with the same features of bilateral nasal obstruction and small fluctuant swelling, then again it will be abscess, because hematoma will convert into abscess if not treated in 1 to 2 days. Then again frontal headache, malaise, so this will be increase in intensity. Signs. On examination, there will be swelling of the nose or the facial swelling. There will be marked tenderness over the bridge of nose. There will be bilateral swelling of the nasal septum. The septal mucosa may be congested, and as it is infection, so there may be enlargement of the submandibular lymph nodes, as this is level 1B, which drain the nasal septum area. So in this picture you can observe there is marked swelling, especially of the nasal tip. Yeah, this area is also swollen, but this in nasal bone fracture, usually bridge of nose will be swollen, but in this hematoma or abscess, this area is more swollen. Okay, and on examining, you see the swelling in both nasal cavities. Treatment. As any abscess throughout the body, it should be treated with incision and drainage. Same goes for the septal abscess. So the abscess should be incised and drained as early as possible. Otherwise, the infection may spread and it will lead to life-threatening complication. Pus, along with the necrosed pieces of the cartilage, should be removed by suction or instruments, but they should be removed. They should not be left there inside. And systemic antibiotics started after as soon the diagnosis is made, especially more preferably they should be given intravenously, and they should be continued for 10 days. 2-3 days intravenous injections of antibiotics and then oral. So this is the septal abscess, looks more of an abscess as the swelling is more severe. So but after only incising you can further identify that it is a hematoma or an abscess. So you give incision at the most dependent part, okay, and put the suction inside and drain out. Complications: necrosis of the septal cartilage, depression of the suppurative nose giving rise to saddle nose deformity. There will be septal perforation, necrosis of the septal flaps, the mucoperichondrial flaps. It can lead to necrosis of those flaps as well. Now the life-threatening complications or the serious complications are they are also serious, but they are local complications. This can be meningitis and cavernous sinus thrombosis, which can, if not treated, will lead to death. So this picture, after draining, you see all the sport, the cartilage sport, it has destroyed or necrosed due to the abscess. So on pressing, you see there is no sport and it is pressed down, and this patient now need rhinoplasty later in the life, at least 6 months after, 3 to 6 months after this current situation of drainage of the abscess. Perforation of nasal septum. So this is a perforation. Etiology, mostly it is traumatic after septal surgery, nasal nose picking, or septal cauterization to control the bleeding. So what happens during the septoplasty or SMR, if the mucosal tears, the mucoperichondrial tear occurs simultaneously at the on both sides at the same level, it can give rise to perforation. Or if you remove the piece of cartilage without elevating the mucoperichondrium, again, then it will definitely give rise to septal perforation. Again, if you do cautery too deep, it can give rise to perforation. Or if you cauterize both sides, usually we don't cauterize if both sides of little areas they are bleeding at the same spot. We don't cauterize the both sides at the same time, because there will be chances of then perforation. Then pathological perforations, either due to infections, especially the septal abscess, or nasal myiasis, which is maggots inside the nose. Any neglected foreign body, especially the chemical one. Which chemical one? The batteries. They are very dangerous foreign body and they should be dealt with immediately. Or chronic granulomatous conditions like tuberculosis, Wagner's, syphilis, leprosy. Other less rare causes are the nasal inhalant irritants like the snuff or cocaine or any other addicted material snuff in through the nose. Malignancy or idiopathic. There may be no any cause for the perforation. Clinical features. It mainly depends upon the size of the perforation. So for small perforations, only whistling sound during respiration can be a complaint, can be a problem, because when the air it passes through the small hole, like you whistle, so the whistling sound can come, like the Bernoulli's principle. However, the large perforations, it will give rise to dryness inside the nose. Patient again present with blockage. Okay, although if you see that the whole of the nasal cavity now become one because of the large perforation, but what happened? There will be too much nasal crusting, and this crust will give rise to nasal blockage, and it can lead to epistaxis once the crust try to be removed. Investigations. Usually, if we know that the patient has undergone surgery, there is no need for any investigation. Investigations are mainly needed in non-traumatic cases. So, you can do blood CBC with ESR, biopsy of the granulations or from the edge of perforation should be done to see what is the underlying pathology, any granulatous condition or malignancy or whatever. So if we look at this picture, this is a small perforation. This is a medium sized perforation, but there is, you see, mild swelling around the edge of perforation. And this is a large perforation. We can see through and through. This is the opposite part of the side of the nose. Treatment. Small perforations, they can be surgically closed by by flaps, plastic flaps through the inferior turbinate or the septal flap itself. and if it is not causing too much problem, then there is no need to do any treatment. However, for large perforations, because that there are not too much treatment options available, because they are very difficult to close surgically. Aim is to keep the nose crust free. Okay, as I already mentioned, all the problems in large perforations is due to crusting, so nose has to be made crust free by alkaline nasal douches and application of the blend ointment. Okay, so the inside it will remain wet. Even you can apply olive oil, it is also a very good lubricant. Celastic buttons, they can be worn to get relief of symptoms. So this is the silicone celastic button. These are usually used to close the or fill up the perforation. These are not suitable for very large perforations, so small to medium size perforation they can be covered up using this elastic button. This is the inferior turbinate. So this button, it helps reduce the crusting and bleeding and other symptoms of the perforation. However, they should not be used in active infection or swelling when there is swelling. Again, this is a non-surgical technique, and different studies, the results are not very promising. Different studies have shown that the tolerability of this button is not very good among patients. Nasal synecdoche, this is the last topic in the septal diseases. So it is also known as the nasal adhesions. Adhesions are basically what happens when the lateral and the medial walls of the nose, they get fused with each other, or when the two walls, the medial and the lateral wall of the nose, they fuse with each other, it will give rise to adhesions. We call those adhesions. Adhesions are common, although a minor complication of nasal or sinus surgery or nasal packing. So this is the adhesion. You see, this is the septum, this is the turbinate, and they are joined together with connection. This connection is known as nasal synecdoche or adhesions, because they need to be cut. This is the endoscopic picture. You see, now you can more clearly visualize that these are the adhesions between the septum and the turbinate. Again, nasal septum, here the adhesions are very much marked, too marked. Okay, this is just small cut will release, rest is all okay, but here it's all of the more than 2/3 of the medial and lateral wall, they are joined with these adhesions. So these adhesions, this can be done under local, but it needs to be done under general anesthesia. Etiology: any trauma inside the nose will lead to mucosal or epithelial inflammation or ulceration, leading to synecdoche formation. So most commonly, as I already mentioned, happens in the nasal surgery, followed by septoplasty, SMR, FES, and polypectomy. These are all nasal procedures. So if we are too much rough, if a doctor has caused too much damage inside, especially when we are dealing with the turbinate, so when they are burned, so the surface burning will cause the irregularity, and if the protection is not done there, what protection I will tell you later on, it's basically the splints we place. So it can cause meeting of the medial and lateral walls and nasal synecdoche formation. Then anterior nasal packing, if one is too rough in inserting the pack and causing damage to the lateral or the medial wall, then it can give rise to etiology. Trauma due to any reason, or again the foreign body, neglected foreign body, any foreign body retained too much inside, or any attempts in removing by untrained or unskilled person, can all later on give rise to this complication. Symptoms: the main symptom can be nasal obstruction. if the adhesion is very small or small in number or and as very small portion, then it may be just an incidental finding and patient may not have any symptom. Then nasal discharge can also be there because the drainage will not be proper due to blockage in the flow. And again, as I shown you that too extensive adhesions, those adhesions can give rise to sinusitis, must give rise to that. Signs on examination, there will be nasal adhesions. You see here the adhesion lies between, this is the inferior turbinate and septum, or between the turbinate and the lateral wall, turbinate with the lateral nasal wall. This is the septum. This area is all cleared up, but this osteomeatal complex region, it will be now closed. So in such cases, the patient will present to you sinusitis. This type of adhesions usually happened after functional endoscopic sinus surgery. Treatment. So surgical removal of synecdoche. First I will tell you how to prevent this synecdoche formation. So after all these surgeries, one has to place the splints. These are the nasal splints which we need to put inside. Sometimes, although most of the time once the splint is placed, the chances of nasal synecdoche formation is very less, but again it can happen, but mostly these adhesions they form in those patients in which doctor has not placed the splints. So surgical removal of synecdoche under local anesthesia or general anesthesia with a surgical knife, cautery or laser. Laser is the best. And after removing, place the splints. Okay. So these are different types of splints. What we usually do, we place the splints. We always place the splints, and in our OPD, in our hospital, our patients, we have the formation of nasal synecdoche is very, very less common. This was one of my patient who developed nasal synecdoche, and this is the post breakage of the synecdoche. You see there it is cauterized, both ends it was cut and cauterized, and now you see it's all patent. Thank you.